Hi everyone. Can you all listen to me? Can you all hear me? Can you all see me fine? I have come little bit earlier so that I can get accustomed to this YouTube live thing. Little new for me. Yeah. Hi. So whosoever joins this medical Olympiad, they can simply start by giving me a thumbs up and we will start at 6. I have some exciting quiz questions for you all. Just a second. Yeah. Hi. So what I'm going to do is, hi Karthik, good evening. I'm just going to, before I forget, write the Patho Olympiad Patho quiz winner from yesterday. That is Dr. Priya Bahl. She is from SPMC Bikaner. So Dr. Priya, you can contact the concerned authorities and you can collect your prize. You have performed exceptionally well yesterday and therefore you have been declared as the winner. Winner of today's quiz will be declared tomorrow by the next faculty, right? All right. So we still have 3 minutes of time with us. Good evening, ABC. How are you guys doing? So what I have done here is, first of all, can you all see me, hear me fine? Audio video is good. Good evening, Blypab. Bye, Plab. So since this is a quiz and we normally discuss anesthesia in very easy terms, we discuss it the way it is being asked. Uh, but for quiz, I have done something very exciting. I have tried to amalgamate the clinical aspect of anesthesia, which is not so easy, let me tell you. And I have tried to merge it with the knowledge that we need to have for our exam. Okay. How many of you are here? Can you all give me a thumbs up? So that I know, and then we can start. Hi Karthik. Wonderful. So I want you all to really step up your senses. It's going to be a very nice session. Hi Barkha, Karthik, Arpan. So what I have planned for you guys is a set of clinically oriented questions. So I thought, why to again do the same type of questions that we normally do? So I've found a completely new type of question so that it kind of initiates a thought process in you regarding how we apply the knowledge of our anesthesia in the conduct and the clinical aspect of anesthesia, right? So there are some very easy questions, there are some moderately level questions, few very tough questions. But what is important is that how much are you able to think about it? How much are you able to apply your knowledge and then give an answer? All right. So I am going to put up a question. I am going to read a question. Don't be in a hurry to to tell me the answer. You have to understand, don't be in a hurry to tell me the answer. The answer is for you. And the way I want you to answer is, I always want you to answer with a justification for that answer. So don't be in a hurry ki, okay, sir has given this question, I'll be the first person to say A, B, C or D. I want you to justify your answer. What is your thought process? So take a minute of your time and justify the answer that you are giving. And that is going to help you when I finally tell you whether your thought process was correct or not. Because maybe sometime looking at the options, you might just mark the right answer by a hunch, or you might simply make a fluke. But I want you to know the thought process behind the answers that you are marking. All right. So again, I will like to announce the name of yesterday's winner of pathology Olympiad. That is Dr. Priya Bahl. Dr. Priya, if you are listening, you can contact the people in the DAMS, the number that has been displayed here, or you can contact at the number that was shown, and you can claim your surprise gift. All right. She is from SPMC Bikaner. So shall we start? Wonderful. So let's start with the first question. Yes, this is a question that I want to ask you. Okay. So a 47-year-old male with a history of difficult airway previously, severe obstructive sleep apnea OSA, body mass index of 45 for an emergent exploratory laparoscopy for incarcerated inguinal hernia. Vital signs are normal in preoperative area, undergoes an uncomplicated induction and easy placement of an oral endotracheal tube via video laryngoscopy. The anesthesiology resident opts for maintenance with isoflurane, fentanyl, rocuronium. The case proceeds without complication and Sugamadex is used to revert the effects of rocuronium. Was administered after noting a train of 4 of 2/4. He is extubated in the operating room, taken to post anesthesia care unit. Upon arrival at PACU, the nurse notes that he remains somnolent. somnolent, requiring an oral airway with retractions and mild obstruction. The attending anesthesiologist arrives at the PSU and discusses the ideal choice of volatile anesthetic agent with this agent. Again, Neil, I have not yet shown you the options, right? So hold your train of thoughts. I want you to give me a justification for the answer that you are giving. I just don't want the answer, okay? The ideal volatile anesthetic agent for the maintenance of this patient should have following characteristics. So I want you all to read the questions carefully. Whenever you have a long question like this, it's a clinical question. There are a lot of irrelevant information. The information which doesn't make any case for the question that has been given to you. Okay. So you have to know how to filter out the unnecessary information. So you have a 47-year-old with a history of difficult airway, with severe obstruction, obstructive sleep apnea, with BMI 45, that means morbidly obese, for an emergency surgery. You don't have time for preoperative optimization. And his vital signs are okay. Everything else is uneventful. But still in the post-operative period, the patient is somnolent, that is under the influence of anesthesia, that is not wide awake, the patient is still drowsy, and the patient is showing mild obstruction requiring an oral airway to keep the tongue, prevent the tongue from falling. So if you have to discuss the choice of ideal anesthetic agent in this patient, then these are your options. Most lipophilic volatile should be used in order to attempt to speed emergence. Least volatile anesthetic agent should be in order to decrease the amount of volatile that redistributes to peripheral tissues. A volatile anesthetic with mild analgesic property should be used to limit the amount of opioids required for the patient. And a highly metabolized volatile anesthetic agent should be used. Highly metabolized volatile anesthetic agent should be used. Now tell me your answer and tell me your justification for the answer. Right, Neil? So the options are not asking you what you should have used, but the option is asking you what should be the choice of ideal anesthetic agent. Okay, Ankit, Shashank, Arpan, I want you to give a small justification for the same. Why do you think B is the correct answer? Right. Perfect. Perfect. So not only that your answer is correct, all of you, but also your justification is correct that the least soluble volatile anesthetic agent will get redistributed least to the peripheral tissue. Now, the problem that you see here is not a problem of reversal of neuromuscular blocking agent. This is a problem of delayed recovery from anesthesia because of use of agents that have longer effect. When we talk about inhaled anesthetic agents, then we talk about their pharmacokinetic properties, and there are two pharmacokinetic properties that we discuss. We discuss something called as blood gas partition coefficient, and we discuss something called as MAC, which is minimum alveolar concentration. Minimum alveolar concentration. Okay, Jyotsna, MAC is inversely proportional to solubility. Is it always the same? Higher the MAC, lower the solubility, lower the MAC, higher the solubility? And Ankit, when you say desflurane is most stable, what do you mean by stable? Which inhaled anesthetic agent is unstable? And what do you mean by unstable? So your words are very, very important. ठीक? Blood gas partition coefficient is a measure of solubility of inhaled anesthetic agent, while MAC decides the potency. When we say solubility, this decides the speed of onset and recovery, because they always follow the same order, onset and recovery, while potency tells us about the dose. And we know that solubility is inversely proportional to speed. So if you have higher solubility, that is higher lipophilicity, then higher would be, longer would be the onset and the offset times. Longer would be the offset and the onset times. While if you have higher MAC, that is inversely proportional to potency. Obviously, if you require higher dose for the same effect, then you will have lesser potency. According to this, the least soluble inhaled anesthetic agent should be fastest, and according to the list, xenon has least blood gas partition coefficient, that is 0.15, and therefore it is fastest onset and recovery. So ideally, if you have xenon with you, then for this patient, what would be your choice of inhaled anesthetic agent? Xenon. But it is not available for clinical use. So the one that we use for clinical use is desflurane, which is fastest volatile anesthetic agent. Because xenon is a pure gas. So the fastest volatile anesthetic agent is desflurane. If you look at MAC, then nitrous oxide has highest MAC, that is least potency. Highest MAC 104. That means it is least potent. While if you look at desflurane, then it has got highest MAC in volatile anesthetic agent, 6.6. So it is least potent volatile anesthetic agent. Least potent volatile anesthetic agent. Right? So this is the correlation between MAC, potency, solubility and speed. Solubility and speed. Alright? So the correct answer to this question is that you would want least soluble volatile anesthetic agent that will redistribute less to the peripheral tissue, and therefore later on the agent will not keep coming into the alveoli and causing the desired effect, right? Right. Question number 2. Are we all good? Should we move ahead to the second question? A 0.5 minimum alveolar concentration isoflurane along with a mixture of 50% nitrous, 50% air is administered for DNC. At the end of the case, iso and nitrous are discontinued. Oxygen saturation drops from 100 to 92. What is the most likely explanation? What is the most likely explanation? What is the most likely explanation? You are using a mixture of 50% nitrous, 50% air with 0.5 MAC of isoflurane, and at the end of the case you see a drop in the saturation. What does this point towards? Wonderful. This points towards, yes, all of you are absolutely correct. That is diffusion hypoxia. Diffusion hypoxia. Now a question that is related to this. Can you tell me which property of nitrous oxide causes diffusion hypoxia? Which property of nitrous oxide causes diffusion hypoxia? What is the reason for diffusion hypoxia? There is one property of nitrous oxide that causes three effects, three clinical effects. Third gas effect, Fink effect due to rapid movement of nitrous oxide. Okay. Fink effect is another name for diffusion hypoxia. Very good, Shashank. I'll give it to you. Gokul, you will have to go and find out the third gas effect. I have never seen a third gas effect terminology in anesthesia. Vapor pressure. Very good, ABC. Vapor pressure. Wonderful. Can you justify how is vapor pressure of a pure gas? Nitrous oxide is a pure gas. So how do you talk about vapor pressure of a pure gas? When you say vapor pressure, it has to be a liquid whose vapors put a pressure on the surrounding of the container in which it is kept. So if you are talking about a pure gas, then how are you talking about vapor pressure? So you all are talking about third gas effect. Is it something that has been taught to you by someone? PaO2. Second gas effect. Okay. So all of you know what this is, but nobody is telling me exactly why this happens. Which property of nitrous oxide is actually responsible for making this happen? Excretion. Gokul, excretion. Do we talk about excretion when we talk about inhaled anesthetic agent? Very good, Josna. You said high solubility. You said high solubility. So you said that MAC and solubility are inversely proportional. Jyotsna, am I right? MAC is inversely proportional to solubility. So you have considered that any agent that is very high, very less potent should be very high soluble. Hai na? So high soluble should have very slow onset and very slow recovery. Would we use something like that in clinical anesthesia? Something that is very slow in onset, very slow in recovery? Right. So none of you are able to tell me the reason for diffusion hypoxia. Ultimately, you know the correct answer, but nobody knows the concept. So the concept is simple. The concept is based on the fact that nitrous oxide is 35 times more diffusible than nitrogen. That means it moves across membranes 35 times faster than nitrogen. Then one should ask, sir, why nitrogen? Why are we comparing with nitrogen? Because nitrogen is the dominant gas of air. Dominant gas of air that we breathe. The air that we breathe has 79% nitrogen and only 21% oxygen. Right? So when you say high solubility, does that mean it will have higher diffusion in the alveoli? Jyotsna, you are making two contradictory statements. Something that is highly soluble will get in very slowly, come out very slowly. Then Bhargavi is just giving me one word answers like density, vapor pressure. है ना? तो उल्टा है. Something that is very highly soluble will actually be slow in movement, and one that is less soluble will be faster in the movement. So nitrous oxide is actually very, very less soluble. If you see here, xenon has a blood gas partition coefficient of 0.15, which is least, so it is fastest. Then DES has 0.2 and nitrous oxide is 0.47. which is third in the list of solubility. Less solubility, right? So it's actually very, very less soluble. So this is the property based on which we see three effects of nitrous oxide. Three effects of nitrous oxide. One you see at induction, one during the surgery, and one at recovery. All of them are based on this property. Can you tell me at induction, because of this 35 times more solubility, diffusibility of nitrous oxide as compared to nitrogen, what effect do you see? At induction, you see the thing that you are all talking about, that is second gas effect, where diffusion of high concentration of nitrous oxide in the alveoli causes faster induction. Faster induction if you use nitrous oxide. Faster induction. During the surgery, this high diffusion in the closed air filled spaces causes expansion. Expansion of closed air filled spaces, right? So if you have an embolus, it will become bigger. If you have pneumothorax, it will become tension pneumothorax. If you have air under dura, pneumocephalus, it will expand and increase ICP. If you have an intraocular air bubble, it will expand and increase IOP. So anywhere in the body, if you have a closed air filled cavity, you would avoid the use of nitrous oxide because of the fear of expansion. And at recovery, you see something called as diffusion hypoxia or Fink effect. Diffusion hypoxia or Fink effect, right? Thereby, large volume diffusion of nitrous back in the alveoli will cause alveolar dilution of air, which will lead to hypoxia, right? Alveolar dilution of air, which will lead to hypoxia. See, I can see the screen fine, ABC. Maybe you will have to check your network again. Okay. Now, what can you do to prevent this complication? How can you prevent this complication? Can anybody tell me how you can prevent this complication? You have the clinical picture in front of you. You were using 0.5 Mac isoflurane, nitrous oxide air. At the end, the patient becomes hypoxic. Is there a way you can prevent this from happening? Is there a way you can prevent this from happening? Is there a way you can prevent this from happening? This is happening. Very good, Karthik. I am so proud of you. Very good, ABC. Perfect. 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 So Karthik, ABC, Arun, Bhargavi, you all are just perfect. You will do pre-oxygenation. Pre-oxygenation. Acha, tell me, do you know the meaning of the word pre in pre-oxygenation? Do you remember or know the meaning of the word pre in pre-oxygenation? Very good. For 3 minutes of tidal volume. Perfect, Karthik. Just tell me, what do you understand by pre in pre-oxygenation? Why is it written pre-oxygenation? It is pre to what? It is pre to what? When you say pre-oxygenation, it is pre to what? Before induction, Anuradha. Are you sure? Before induction. Before intubation, ABC. Very good. So you know that when I say pre-oxygenation, Karthik, very good. Bhargavi, before induction, why did you delete it? Suddenly you had an epiphany that, oh, if pre-oxygenation is before induction, then how come I am saying the answer as pre-oxygenation? Extubation, Gokul, U-turn maar liya. Pre-oxygenation is before extubation. See, we all know pre-oxygenation, the word pre means before induction. Before induction, the patient is awake, and an awake patient breathes spontaneously. So when we say pre-oxygenation, that means we are doing it before induction. When do you see diffusion hypoxia? Before the end of the surgery, in the recovery period. So will your pre-oxygenation that happens at the start of the surgery in any way help you preventing something that is happening at the end of the surgery? Something that is happening at the end of the surgery? No. So pre-oxygenation as an answer is wrong, and this is actually a previous year question where they give you a picture of diffusion hypoxia and they asked you what is the best way of preventing. The first option was pre-oxygenation, and maximum people just like you answered pre-oxygenation thinking कि हाँ sir oxygen का problem है, will give oxygen. Yes, that is supplementation of oxygen before the end of surgery. It is not pre-oxygenation. Pre-oxygenation as an entity is only done before induction. So if you want to avoid diffusion hypoxia, then you supplement 100% oxygen before recovery. And इसका कोई time period नहीं है. It is just several minutes. So when you know that the surgery is about to get over, don't wait till the last to switch off the nitrous oxide. Switch off nitrous oxide few minutes before. Let the patient breathe 100% oxygen, and what will happen, whatever nitrous is diffusing back in the alveoli, that will never create a hypoxic atmosphere. Why? Because you will always have higher concentration of oxygen in the alveoli, right? So again, I told you, knowing the correct answer is not the only thing. Sometimes we get trapped in this thing that we know the correct answer, so we know everything. It is the concept behind that topic which is important. So when I say that you have to do previous year question for your exam, I don't mean that you only go and you do a rectification of just the question, answer. That means you tend to the topic, you discuss the topic, and then only you move ahead. Okay. Let's come to question number 3. I think now we can go a little faster because now we have come into this groove and I see a lot of movement from you, a lot of chat from you. So let's start with question number 3. A 65-year-old female with a history of interstitial lung disease presented with hospital with productive cough, fever 102, on examination heart rate 110, respiratory 32, blood pressure 92/74, initial lab hemoglobin 10.6, WBC 18,000, platelet 180, creatinine 1.8, bilirubin 1.6. 6 hours after presentation develops hypoxemia with O2 saturation 70% on room air. Blood gas reveals pH of 7.5, PaO2 of 48, PCO2 of 26, bicarb of 24. On examination, there are bilateral coarse crackles. Chest X-ray reveals infiltrate all over the lung zone. Patient underwent emergency endotracheal intubation due to acute respiratory failure, started on broad spectrum antibiotics for sepsis. 24 hours later, the patient develops tachypnea and tachycardia. FiO2 needs to be increased to 0.8 from 0.4 due to hypoxia. Currently, the ventilator is on volume control, FiO2 0.8, PEEP of 10, tidal volume 8, cc per kg, and respiratory rate of 18. Chest X-ray is obtained, which shows worsening of previous findings. What is the most appropriate next step? What is the most appropriate next step? I want the diagnosis. Before you answer the question, I want the diagnosis. What is happening to this patient? What is the clinical condition shown here? And what has happened to the patient after that? What is the clinical condition? Anyone? Take your time. It's a long question. Okay. Anuradha says ARDS. ज्योत्सना, कार्तिक, एबीसी गायब हो गए क्या? इट्स अ लॉन्ग क्वेश्चन. I told you there'll be some brainstorming that needs to be done. Pulmonary edema, very good. That is a new thing, pulmonary edema. Why would there be pulmonary edema in a patient with interstitial lung disease with productive cough and fever? Why would there be pulmonary edema? Just because you see that there are bilateral coarse crackles and you see that there are infiltrates in all over the lung zones. If it is pulmonary edema, then where would you find the infiltrates? Base of the lung. That is where the water accumulates. Would you directly get infiltrates all over the lung in pulmonary edema? Is that how pulmonary edema works like? See, pulmonary edema would have a cardiac reason or a non-cardiac reason. Non-cardiac reason is usually very rare. It's the cardiac reason that is a very common cause of pulmonary edema. What part of this tells you that this is pulmonary edema? Nothing tells you this is pulmonary edema. This is a classical picture of ARDS, acute respiratory distress syndrome, that you are managing by ventilation and antibiotics, isn't it? And even after doing ventilation and antibiotics, there is worsening of the symptoms, worsening of the patient. So a ARDS patient who is on management has worsening of symptoms. Yes, very good, Bhargavi. Very, very good. This is a typical case of villi, which is ventilator induced lung injury. When you have a patient on ventilator who is not improving, then you can suspect that there is villi, and the reason there is villi is because you are using a high tidal volume. So what you will do is you will reduce the tidal volume to 6 cc per kg. 6 cc per kg, low tidal volume. PEEP 10 is okay. In ARDS, high PEEP is a norm. This is moderately high PEEP. Normally you keep it between 5, 6. You can go go up till 15 if the hemodynamics they permit. So 5 cc per kg is too high a PEEP. If the patient is say 50, 60 kg, then this would mean 300 PEEP. So this option is only wrong. Add anti-pseudomonal agent? No, there is no role of antibiotics here. You are already taking care of the infection by broad spectrum antibiotics. And administer diuretics, not really going to help. But I can understand why, looking at the option you thought it might be pulmonary edema. And looking at the option you thought, okay, if you have to give diuretics, then it could be pulmonary edema. No, in pulmonary edema, you need to have a reason for having pulmonary edema, and you will not have infiltrates all around the lung in pulmonary edema. It will be mostly up till the basis, and you need to have some cardiac problem with the patient, or fluid overload, or anything that suggests that there should be transudative or exudative fluid that is coming out from the lungs, out of the alveoli and going into the interstitium. Okay, right? So the correct answer to this question is lower the tidal volume to 6 cc per kg. I won't call it a very easy question, but I just wanted you to use your reasoning. Sometimes you might not know the entire concept, yet you are able to mark the question correctly if you are able to rule out the options. So this answer could have been very, very, very well done by ruling out the options, right? Next is a very easy question. Identify the device and the most unique aspect of it. Identify the device and the most unique aspect of it. Yeah, I'm pretty sure nobody is going to mark this question correct. And this was to elevate your spirits. I have put one easy question in between 2-3 difficult questions. Yes, this is a ProSeal LMA with an esophageal drain port. with a esophageal drain port. But if you see what options I have given, they all are correct. It's just they are not correlating to the image, right? These are all second generation, not all, but 3 of them are second generation LMAs. How do you decide which LMA is a second generation LMA? It has got 2 ports, one ventilating port, ventilating tube, that is even present in first generation, but it has a separate drain tube, esophageal drain tube. It has a separate esophageal drain tube. So if you have to identify a second generation LMA, just find 2 tubes in an LMA. 2 tubes. Now, based on this, we have 3 very common types of second generation LMAs that are being asked: ProSeal, Supreme, and iGel. And the unique things about them helps you in the identification. So whenever I teach you, I always tell you, if you can identify a device without looking at the image, that is the best, because then looking at the image, you will easily identify. So how can you identify these 3 devices without looking at the image? ProSeal has no shape. So 2 lumen, no shape, ProSeal. 2 lumen and anatomical shape. 2 lumen and anatomical shape of the device. The LMA is like this, L-shaped. And 2 lumen and no cuff, a cuffless device would be iGel. 2 lumen and a cuffless device is iGel. So what you see here is 2 lumens. Do you see here? There are 2 lumens. This is the ventilating port. This is the ventilating. You can see this is the tip which is then connected through a tube. This is the esophageal drain tube. So you know it's a second generation LMA. And you see that there is no shape of this LMA. So it is a ProSeal, and ProSeal was first ever second generation LMA was made, and that time having an esophageal drain port obviously gave it an extra edge over the first generation or classic LMA. All right, first generation or classic LMA. Wonderful. Question number 5. 45-year-old man with 20 pack year smoking, persistent asthma, taken to operating room for an emergency surgery after sustaining 18% total body surface area burn, sparing head and neck. Patient is not fasted before procedure. Shortly after induction of anesthesia, endotracheal tube placement, patient's EtCO2 decreased with prolonged expiratory phase. Patient's O2 saturation subsequently begins to decline despite 100% FiO2, and wheeze is auscultated bilaterally. What is the likely cause of patient's current respiratory status? Tell me the diagnosis. Tell me the diagnosis. Forget about the options. Tell me the diagnosis. First, tell me your diagnosis. What has happened to the patient intraoperatively? What has happened to the patient intraoperatively? Anyone? 45-year-old, history of smoking, asthma, taken up for an emergency surgery, induced, intubated. Suddenly you see that the capno is going down, the patient's saturation is going down even with 100% oxygen, and you can auscultate that there are bilateral wheeze. Karthik, respiratory depression. You have already intubated the patient. Why would there be respiratory depression? You have already intubated the patient. You are giving 100% oxygen to the patient who is ventilating. So how can you say respiratory depression? Emphysema. Okay. So the patient has emphysema. Does that mean the patient will desaturate under anesthesia? Sri Ramya, emphysema is not the reason you give for somebody's hypoxia. Wrong side tube. Okay. Tell me which is the right side of putting the tube. Aspiration. Wonderful. Aspiration. So aspiration will start decreasing the EtCO2 and saturation immediately. Hyperventilation. So you have done hyperventilation, and hyperventilation, will it cause fall in the saturation? Will it cause wheezing? Arun, I'm still waiting for the answer from you, which is the right side of the tube. When you say wrong side tube, tell me what is the right side of the tube. Respiratory failure. After giving the correct answer, Bhargav, you suddenly went back to respiratory failure. You have induced the patient. What do you mean by inducing? You have already given the patient anesthesia. You've taken patient's ability to breathe. There is no question of respiratory failure. You have taken the matters in your own hands. You have given muscle relaxant. You have intubated the patient and you have put the patient on ventilator. There is no question of respiratory failure here. And will respiratory failure means that you will start getting wheeze? This is a typical case of intrabronchus. So that is the wrong side. Arun, is that the wrong side? So you don't say wrong side, then you say endobronchial intubation. Because when you say wrong side, that means if I say it is in the right bronchus, then it means that the left bronchus is the right side. No. The tube is ideally supposed to be in the trachea. If it goes endobronchially, then yes, you might get fall in the saturation. But will you get wheeze? COPD exacerbation, bronchospasm. Again, why mix two things? COPD exacerbation is exacerbation of the cough that happens over a period of time. It has nothing to do with what we are trying to have here. We are trying to have somebody with a reactive airway. We have somebody with a reactive airway, isn't it? Somebody with 20 pack years of smoking and a persistent asthma has a reactive airway, and the patient is posted for an emergency surgery and is non-fasted. So what is the kind of anesthesia induction technique that you will use in this patient? You will use something called as RSI, which is rapid sequence induction or intubation, which is used to prevent aspiration in non-fasted patients. Prevent aspiration in non-fasted patients. And when you do RSI, then what are the drugs that you use? In traditional RSI, you use thiopentone for induction and scoline for muscle relaxation. They both release histamine, and reactive airway with release of histamine can cause bronchospasm. And this was actually a retrograde diagnosis that I wanted. Bronchospasm shows wheezing and fall in the saturation. So the moment you saw wheezing in your question, it should tell you it is bronchospasm. Bronchospasm should tell you histamine release. Histamine release should tell you thioscoline, which should tell you RSI. And therefore, the correct answer to this question is drug used in the induction. Drug used in the induction. Placement of endotracheal tube in esophagus will not give you bilateral wheeze. Obviously, there will be fall in saturation, but there would not be any wheeze because your tube is not present in the trachea. No wheeze. Tracheoesophageal fistula in an adult, untreated, not possible. TEF is a neonatal emergency. Okay. Malfunction of inspiratory valve of the anesthesia machine will not cause prolongation of the expiratory phase. If there is inspiratory valve problem, then you will get something like this. which is the inspiratory phase prolongation, right? While what you see in bronchospasm is something like this, which is the prolongation of the expiratory phase. All right, prolongation of the expiratory phase. So this was what I felt was a easy question, but it's okay. You guys need to look at the clinical picture and then go back and try and find. These are not easy questions at all in terms of your exam, but I just want to cover maximum things and I want you to think clinically, think in the direction of how you would see stuff intraoperatively. Okay. Question number 6. A 25-year-old woman at 32 weeks gestation arrives in labor and delivery triage complaining of severe abdominal pain, uterine contractions, otherwise healthy, weight is 100, fetal heart rate reveals severe bradycardia. Acute placental abruption is suspected diagnosis, decision to proceed with emergent cesarean section. Anesthesia is induced with propofol, scoline with cricoid pressure. 3 attempts at laryngoscopy have failed. A Cormack-Lihani 2B is the best view obtained despite removing cricoid pressure. Nursing staff is looking for unit's difficult airway card. No other anesthetist is in the unit and the emergency department has been called for immediate assistance. Okay. The pulse oximeter is currently reading 96. The patient is started to breathe again. Obstetrician informs you they must operate immediately. Some supraglottic airway is available. Which of the following best next step in the management of this patient? Which is the next best step in the management of this patient? Next best step in the management of this patient. So tell me the scenario, then I will tell you the options. Tell me the scenario. What is happening here? What is this scenario? A 25-year-old, 32-week of gestation. You tried to give general anesthesia to the patient. You gave propofol, scoline, cricoid pressure, laryngoscopy. You found CL grading 2B. Forget about this 2A, 2B. Just remember that you found it something like this. You found something like this. So this looks like a difficult airway algorithm. Very good. This looks like a difficult airway algorithm, isn't it? And whenever there is a difficult airway, you follow difficult airway algorithm, which has got plan A, B, C, D. Now this is what is happening. These are the options. Continue the anesthetic by mass, maintaining cricoid pressure, proceed with delivery. Attempt placement of supraglottic airway. If the supraglottic airway is well positioned, proceed with delivery. Attempt placement of tracheostomy tube and then proceed with delivery. Attempt blind nasal in an effort to intubate prior to proceeding with delivery. What would you do? What would you do? Justify करो. कार्तिक, ABC, शशांक, justify. यार ABC लिख के दूसरों का ऑप्शन देख के don't delete. It's okay. Even if you answer wrong, that is fine, but don't delete. Don't look at others' answers and then think, oh shit, galti ho gayi. It's okay. The whole idea of conducting a quiz is this only. We are trying to emulate what happens in the exam. Okay, question is something like this. The question is telling you, Jyotsna, the question is telling you that you are not able to intubate the patient. So there should be no question ki sir, why 2B mein there is easy or difficult. Trying to understand. CL grading is laryngoscopic view. Ultimately, the tube has to go inside the trachea. So the intubator is not able to put the tube in the trachea for whatever XYZ reason. I don't want you to think about 2A, 2B, 3A, 3B. That is beyond the scope of our understanding. But what the point is that it is a difficult airway algorithm, and in difficult airway algorithm, you have got plans, which is plan A, B, C, and D. A is laryngoscopy and intubation, which the anesthetist was trying to do. But when the anesthetist fails to do this laryngoscopy and intubation, you move to plan B, which is supraglottic airway device, right? And if you are successful, you go ahead with the surgery. It is an emergency surgery. You have to go ahead. If you fail here, then final attempt at face mask ventilation. But here there is no option of going ahead with the surgery. You have to defer the surgery even if it is an emergency. Because without airway, you cannot go ahead with the surgery. The patient will die. And if you are at D, then you do cricothyroidotomy. Cricothyroidotomy. Just a second. Right? Cricothyroidotomy. So when you say tracheostomy, then again you are wrong, because one, after 3 attempts of laryngoscopy failed, you will not directly go with surgical airway. It is a crime. Secondly, tracheostomy is never a procedure that can be done immediately. At best, even in best hands, it will still take at least 10 to 15 minutes to perform a tracheostomy, right? You cannot continue the anesthetic by mass and do an LSCS, because you cannot maintain that level of anesthesia, plus the patient will have very high risk of aspiration. You should not attempt blind nasal in a patient where already laryngoscopy is difficult. Best is if you have a supraglottic airway device and it is well positioned, then you go ahead with the delivery. Only when you have a patent airway where you can deliver inhaled anesthetic agent and oxygen to the patient, then you go ahead with the surgery. So the correct answer to this question is option B, which is also the plan B of difficult airway algorithm. Plan B of difficult airway algorithm. All right. Question number 7. A 78-year-old male with a positive history of smoking, hypertension presented to clinic with complaints of nocturia, hesitancy, poor urine stream for past 7 months. On digital rectal examination, clinician palpated enlarged mass anteriorly, which was firm, nodular, non-tender. Anterior sulcus could not be appreciated. Patient had normal prostate-specific antigen, large post-void residual urine, and his transrectal ultrasonography confirmed the diagnosis of BPH, benign prostate hyperplasia. Surgeon planned for TURP. Detailed medical history revealed that the patient has ischemic heart disease, suffered 2 episodes of MI. ECG shows no active cardiac condition, but EF is 35. Planned for saddle block. What is the advantage of spinal saddle block hold over subarachnoid block in this given case? Subarachnoid block in this given case. What is the advantage? Now you can see the first 6 lines of this question are irrelevant to your answer, है ना? And this is just a way of distracting and making your concentration go down. Remember, this is just a way of distracting you. So when you get large clinical question, you should know the habit of reading very fast. So the patient has a cardiac condition. You need to go for TURP, and the anesthetist has planned for a saddle block. What is a saddle block? The saddle block is when you only block lower, you can only block the sacral segments and lumbar segments. You keep the level very low. That is a saddle block. So the level of the spinal is kept very low. You keep the patient in sitting position. You give the drug. You make the patient sit for 10 minutes. So all the drug, it kind of permeates down and the level doesn't go up. If the level is not going up, the sympathetic supply, the sympathectomy is less, and therefore you will have less hemodynamic change. Yes, the correct answer is C. Reduces the risk of circulatory overload. Why would it prevent the need for tracheal intubation? See, spinal and saddle, they both are type of spinal anesthesia only. And once you give regional anesthesia, you anyway are avoiding tracheal intubation. Post-operative analgesia, both will give. Reduce the incidence of post-operative urinary retention, doesn't matter. In a TURP, you anyway keep the catheter for 48 to 36 hours. There is no question of post-operative urinary retention. Okay. Here the point is that the patient has low EF and is a known cardiac patient. So you don't want circulatory overload in this patient. You don't want a circulatory overload in this patient. Therefore, you will prefer saddle over spinal. All right. Next question. Again, an easy one. Identify the device and its use. Identify the device and its use. Identify the device and its use. So how do you identify devices, airway devices? Okay, so all of you except Arpan. Arpan thinks it is Venturi but low concentration of O2 delivery. So see, how do you identify a Venturi mask? By these valves. Can you see? So if your airway oxygen delivery device has valves of different color, then it is a Venturi mask. And the most important property of Venturi mask is it's a fixed O2 delivery device. Fixed means doesn't change the FiO2 that is delivered. Doesn't change the FiO2 that is delivered. Right? Doesn't change the FiO2. Did not read option D. Why? You are in so much of hurry. You thought that a question can be solved by merely reading 3 options. Something that you have to be very careful of. This is exactly what you will do in exam as well. You will go, you will see the first option, you will feel, हाँ ये तो सही है. You will mark it, go ahead, not read the 3 options. Why has examiner given you 4 options? To read, na? Doesn't take more than 10 seconds to read one more option. There is no point in saving so much time by not reading options. Remember, reading questions and options is something that you have to do. There is no going around it. You have to read the questions and the answers and the options. Remember this thing. Okay. So this is a Venturi mask. Wherever you see the valve, you have to know that it is a Venturi mask and it's a fixed O2 delivery device. Fixed means whatever valve you choose, that valve at a particular level of flow of oxygen delivers a particular concentration of oxygen to the patient. That doesn't change with the characteristics of the patient, with the breathing characteristics of the patient, right? Arpan, I'm very happy that you made this mistake. One, secondly, you admitted it. I am pretty sure after this you will never forget reading an option. So I give full marks to you for one, answering wrong the moment you felt, and secondly, being very true about it. So being true to yourself is something that is utmost important in this year of your preparation, because that is going to keep you always in the race. Okay. All right. Question number 9. A young female found lying on the floor of the gym when you entered there. Okay. You tended to the female and decided to change her position as in the image. What findings did you get that prompted you to give this position? Fresh out of the oven question, isn't it? If you guys know this, this is a fresh out of the oven. What is this position? What is this position? What is this position? Yes, it's a recovery position. Now let's look at the options. Female is non-responsive, not breathing, responsive, not breathing, non-responsive, breathing, responsive, breathing. Okay, Goku, just think of your answer. Pulse present, respiration absent. Pulse present, respiration absent. You put the patient in this position. Will the patient start breathing? Will the patient start breathing? If the patient is not breathing, then don't you think your priority would be to give the breaths? Is breath important for living? Yes. So if a patient is not breathing, then you will not simply turn the patient and leave them, right? This is a recovery position. And whenever you have a collapsed victim, you go and first check for responsiveness. Once you check for responsiveness, there will be two things. Either the patient is responsive, unresponsive. If it is responsive, nothing needs to be done. But if it is unresponsive patient, then you need to check for pulse and respiration. Pulse and respiration. And when pulse and respiration both are not present, then you go for CPR. But when they are present, then you give recovery position to the patient. So it is not cardiac arrest. It is something else that has caused the patient to collapse, and you don't want, one, the patient to aspirate. Second, you want whatever secretions are there, they should come out, and the patient should not have any obstruction in the breathing. So you turn the patient on one side. Turn the patient on one side. Doesn't need to be always left lateral. It is lateral position. It could be left lateral, it could be right lateral. You turn the patient, you fold one leg, you keep one leg straight, one hand below the head of the patient and another hand either like this, or it could be stretched like this. This is called as the recovery position of the patient. Recovery position of the patient. It is done when you have pulse and breathing present in a collapsed victim. And this brings us to the last question for the discussion of the quiz. That is, a patient undergoing shoulder arthroscopy surgery under general anesthesia in beach chair position. You are using a multi-para monitor to keep a watch. Suddenly you notice the capnograph change. You immediately recognize this event, start its management, and everything is settled in 15 minutes. What monitoring technique could you have used to detect this event earlier? What you could have done to detect this earlier? what you could have done to detect this earlier. Diagnosis, and without looking at the options, tell me your answer. Barkha, accidental extubation. Will you see a capnographic waveform? Barkha, will you see a capnographic waveform? Yes, Ashutosh, that is SIMS position. That is SIMS position. SIMS is another name for recovery position. No, capno तो दिखा हुआ है ना. Capno ही तो change हुआ है. Capno तो it is already being given to you. The question is asking what technique could have detected this event earlier. CVP monitoring, very good. Can you justify how CVP monitoring will detect? One, tell me what has happened to the patient. Secondly, tell me how CVP monitoring would be better. Anuradha, I am expecting your answer. Tube block, Rambya, very good. Tube block. So you say that tube block has happened in a patient for shoulder arthroscopy in beach chair position, which has led to sudden decrease in capnography. Will you see sudden decrease in capnography in tube block? If the patient has suppose bitten the tube half, does that mean that the concentration of CO2 that is coming out from the alveoli will decrease? Will it decrease? Leaking endotracheal tube. Again, Karthik, very good. If there is a leak in the endotracheal tube, does that mean whatever CO2 is coming via the endotracheal tube to the transducer will have less concentration? Sensitivity is better in CVP. How? How is CVP monitoring better if your diagnosis is venous air embolism? What will happen in venous air embolism? Okay, sitting position is prone for air embolism, I accept. But tell me how sensitive, how CVP monitoring would be better. Positional hypoxia? Is this something new, Barkha? Positional hypoxia, and I didn't talk about hypoxia at all. Have I given you the SpO2 reading in this whole question? I have shown you a capno. Will there be fall in the capno with hypoxia? Is the capno measuring oxygen or is it measuring CO2? The positional hypoxia is nothing one. Even if you say hypoxia, why would it affect capno? Increase right heart strain. Okay, very good. So when you have a venous air embolism, then you have increased right heart strain. And how does right heart strain show on CVP? I thought right heart strain you can diagnose very easily using an ECG. How does it affect CVP? That is central venous pressure. That is the pressure in the SVC where the tip of your CVP catheter is placed. You said CVP, right? So how? Yes, you can suck the emboli from the right atrium, but will it help you detect it earlier? What monitoring technique? The question is very specific. What monitoring technique? So I am asking you monitoring technique and you are giving me an answer in the form of management. Am I asking you the management? No. Okay, the emboli will increase pulmonary vascular resistance. Okay, again, wonderful. So if there is increase in pulmonary vascular resistance, will that show on CVP? Will that show on CVP? If you have increased pulmonary vascular resistance, which is right here at the level of the pulmonary vasculature, will a catheter placed in the SVC show increased pulmonary artery resistance? Increase in PaCO2. Again, shooting in the dark. So क्या कर रहे हो आप लोग? मिक्स कर रहे हो कॉन्सेप्ट्स को. You are not clarifying your brain. You are not going step by step. Now few people have started to understand what I am trying to say. I am trying to say that you have a shoulder arthroscopy which is done here, which is done in beach chair position. That is a pretty straight position. and there is sudden drop in capno. So the diagnosis is venous air embolism. And we know whenever you have a position that has high risk for venous air embolism, you can place certain monitors to increase your efficiency of diagnosis. And we know that the most sensitive invasive modality is transesophageal echocardiography that will look at the embolus in the heart. Very good. Now to justify your answer, you are saying Swan-Ganz catheter. Now you only tell me, somebody for a shoulder arthroscopy, would you put a Swan-Ganz catheter? And once again, Swan-Ganz catheter will tell you pulmonary hypertension. Does that always mean pulmonary embolism? Does that always mean pulmonary embolism? Like there is only one reason for PAH? Suppose somebody is already a PAH, you put a Swan-Ganz catheter, then how would you identify that there is pulmonary air embolism? No. So simplify the matters that are there in your hand. You have different types of monitoring techniques that help you with early recognition of venous air embolism. One is TEE, that will look at the air embolus in the heart because it is transesophageal echocardiography. Second most sensitive non-invasive modality, which is precordial Doppler. And then you use capnography where you see sudden drop in EtCO2. Yes, you can aspirate air embolism using central venous catheter, not CVP. CVP is central venous pressure. That is what you measure using a central venous catheter. And no, Bhargavi, PCWP for Swan-Ganz is not the correct answer. It can never be the correct answer because even if you put a Swan-Ganz catheter, looking at pulmonary capillary wedge pressure only tells you about pulmonary hypertension. It doesn't tell you the reason for that pulmonary hypertension. I am asking you by what modality you can diagnose venous air embolism earlier. So the correct answer is transesophageal echocardiography. Very simple question. Only Ashutosh and Karthik answered it correctly. Only Ashutosh, Karthik and yes, Bhuvanesh answered it correctly. No, it would never be used in this case. Why would you want to put a Swan-Ganz catheter in such an innocuous procedure like shoulder arthroscopy? In one OT list, we put, it's an advanced hemodynamic monitoring technique. Shoulder, Swan-Ganz catheter or pulmonary artery catheter is an advanced hemodynamic monitoring technique. You don't put it for cases like shoulder arthroscopy. You need to have a cardiac reason to put a Swan-Ganz catheter. Okay, now to even cardiac reasons we don't put. So this is it. This was what I wanted to discuss. I wanted to see you guys have been wonderful. You were very interactive. I'm very, very happy. You applied your brains. Somewhere something was less, but most of the times you were correct. I hope you enjoyed the session. You can fill up this Google sheet and the winners will be declared tomorrow by the next faculty when you come for your next round of Olympiad, right? So all the very best. I'm going to stop the session now. Wonderful. Yes. Thank you. All the best.